Hello, my name is Stuart Carr. I've been the Chief Medical Officer at Snow Asthma and Allergy in Abu Dhabi since January 2019. I spent the previous 20 years in academic clinical allergy practice in Edmonton, Canada. And today I'm going to be discussing the latest understanding of the pathophysiology and clinical manifestations of eosinophilic esophagitis. Well, we are still learning a lot about eosinophilic esophagitis. It is very clearly a multifactorial condition. There is strong evidence of a genetic predisposition. If we look at twin studies, we see that about 40% of monozygotic or identical twins will share an EOE diagnosis. But again, that means that a majority of them don't. So there's obviously other factors involved. It's not quite so simple. There's a lot of different genetic mutations that have been identified in EOE patients, and most of these are associated with type 2 inflammation or epithelial barrier function. Interestingly, there does seem to be an interaction between sort of classically identified atopy or allergy genes as well as EOE specific genes, and the risk is highest in patients who have mutations in both general atopy and EOE specific genes. There's been a long, strong, and consistent male predominance with EOE that we still don't understand fully. And now we're learning about some of the environmental factors that may be associated with an increased risk for developing EOE, including preterm delivery, cesarean section, neonatal intensive care admission, and early antibiotic use, just to name a few. In fact, a recent population and case control study from Denmark found a threefold increased risk for EOE development with preterm delivery. Now, these associations can be a little bit confounding, a little complicated to sort through because, of course, preterm birth is associated with NICU admission, as well as an increased risk of early use of antibiotics. So we're still going to have to do more work to try to tease out which of these may be, in fact, causing or really contributing to the development of the condition. Interestingly, a recent case control study from the United States found weaker but kind of compelling associations for increased EOE risk with metal contamination in drinking water, most notably with mercury, beryllium, and thallium. So again, there's obviously a lot of work to go. Eosinophilic esophagitis is clearly a type 2 condition, and it's characterized by classic Th2 mediators and cytokines such as IL-4, IL-5, and IL-13. There's a strong association between having EOE and having other classic atopic or allergic conditions, such as IgE-mediated food allergy and allergic rhinitis, which are in fact noted in a majority of EOE patients in some studies, and asthma and atopic dermatitis in as many as half. There's also associations with non-atopic conditions such as gastroesophageal reflux and depression. And it's interesting that these conditions are also associated with other allergic phenomena such as asthma. So again, while it is a Th2 and type 2 kind of phenomenon, there's definitely other factors that play a role. This relationship seems to be bidirectional as well. Patients who have food allergy are much more likely to develop EOE, and patients with allergic rhinitis and atopic dermatitis are also about 3 times more likely than the general population. And really interestingly, there's a dose response where patients who have more different atopic comorbidities seem to be in the highest risk group for developing eosinophilic esophagitis. And this association with other atopic conditions seems to be the most strongest in the patients who develop EOE at the youngest ages. This is important, of course, because unraveling the origins of EOE is very important to help better understand the atopic march in general and why some people develop certain type 2 conditions and others don't. Again, we know that it's a relatively small percentage of allergic people who develop eosinophilic esophagitis, and trying to understand better ways to predict and identify these patients early may be very important because there's a well-known diagnostic delay where patients will suffer for many years before the diagnosis of esophagitis is made. And so everything we can do to help facilitate the earlier recognition and diagnosis and then hopefully therefore more appropriate management can have significant potential for modifying the course of this condition and maybe in the future prevent the development of EOE in high-risk individuals. This is a really important question and an issue that we're really struggling with in the allergy world. We know that food antigens in general, and milk in particular, are very important in the development and ongoing pathophysiology of EOE. The problem is the mechanisms behind this remain very much unclear. And I think it's really important to take a moment and really emphasize the fact that EOE is not an IgE-mediated food allergy condition. While we know food triggers are very important for the development and ongoing inflammatory processes with EOE, it isn't through an IgE-mediated mechanism. And our current testing for IgE-mediated hypersensitivity, sort of standard skin or blood testing for food allergy, is simply not able to accurately identify triggering foods for EOE. We know that IgE blocking therapies don't improve EOE, and we know that with few exceptions, EOE trigger foods don't cause anaphylaxis. That's part of why it's so hard to identify their triggers. We also know that successful treatments for food allergies, such as oral immunotherapy, may actually induce EOE in some cases, despite preventing more severe acute reactions. And in animal models, we see that IgE and mast cells are not necessary for the development of EOE. So, of course, this has led to us trying to figure out other mechanisms and other pathways by which the food antigens may play a role. Some recent studies have shown an association with food-specific IgG4 and EOE activity, both in plasma and tissue samples, especially for milk and less frequently shown with wheat. The problem is it's not clear yet if this is a causal mechanism or merely another association. And given the ubiquity of food-specific IgG in the general population as a marker of exposure and immunologic tolerance in most cases, it would be very much premature and inappropriate to begin testing EOE patients for this ubiquitous antibody. Currently, there is really no convincing role for testing EOE patients for either food-specific IgE or IgG4, and we have to acknowledge that such testing will usually give unhelpful and misleading results. So there's a lot of work to do in this area. The recent findings are interesting, and I'm hoping are going to lead us in the right direction, but really not yet at a level of clinical relevance. Eosinophilic esophagitis is a chronic progressive type 2 inflammatory disorder. And very much like allergic asthma, we see evidence of epithelial barrier dysfunction, eosinophil infiltration, mast cell and basophil degranulation, smooth muscle hyperplasia, and eventually tissue remodeling and fibrosis. These changes lead to this sort of classic EOE symptoms of dysphagia, food impaction, and intractable heartburn in adolescents and adults, and a slightly different presentation in younger children with more vomiting, regurgitation, food refusal, and even failure to thrive in some cases. Unfortunately, the nature of this sort of type 2 inflammation driven by IL-4, IL-5, and IL-13 coupled with epithelial barrier dysfunction results in a sort of a positive feedback loop, which leads to progressive chronic inflammatory changes and, again, ultimately tissue remodeling and fibrosis. Reflecting this, a recent long-term study from the United States found an 18% annual increase in the odds of stricture formation for patients with EOE. And males are about twice as likely to present with food impaction than females with EOE. And they're also about twice as likely to require esophageal dilatation, again, speaking to the chronic fibrotic changes that occur over time. Interestingly, there's also a greater likelihood of presenting with food bolus during the spring and summer months compared to the fall and winter months. And this may reflect the role of aeroallergens with EOE. Again, we know that it is a multifactorial condition, and perhaps the overlap with allergic rhinitis and other type 2 conditions. This may speak to immunologic priming as they enter hay fever season. That increased inflammation in the upper airway may result in sort of an increase in the inflammatory response in other parts like the esophagus as well. And these sorts of chronic and again, progressive changes really highlight the importance of early diagnosis and appropriate long-term management and monitoring. It's really critical that we remember that this is a chronic inflammatory condition for which we currently have no cure, and that even when patients appear symptom-free, they may have significant inflammation that may be resulting in chronic changes that will affect them in the long term.
Hello, everyone. I'm Mario Vieira. I'm a pediatric gastroenterologist practicing a 380-bed pediatric referral hospital in Curitiba in the south of Brazil. Today, I'm going to discuss the diagnosis and management of pediatric patients with eosinophilic esophagitis. We have a 6-year-old boy presenting for evaluation of a history of feeding difficulties, mild abdominal pain, and occasional vomiting and gagging associated with eating since he was 4 years old. He avoids meat and fruits, limits his diet to foods with soft textures, prefers liquids, and eats slowly. The mother also reported that he takes a drink after every bite. Weight gain was low in the previous year and stopped in the last 6 months. He has a history of asthma and allergic rhinitis. A positive family history of atopy was also reported. The father has a history of asthma and has dealt with reflux symptoms with frequent heartburn. There were no abnormalities on clinical examination. However, due to his chronic symptoms associated with growth faltering, he was submitted to an upper gastrointestinal endoscopy that showed mucosal edema, white exudates, and linear furrows in the esophagus. Esophageal biopsies revealed over 60 eosinophils per high power field. Symptoms in eosinophilic esophagitis are normally due to esophageal dysfunction, but also can be non-specific, such as abdominal pain, problems with eating, vomiting, and symptoms also vary with age. Younger children, differently from adolescents and adults, are more likely to present non-specific symptoms as nausea, vomiting, abdominal pain, and feeding difficulties. And depending on the duration of the disease, they may also present with growth faltering. Of course, these symptoms may also occur in GERD or in motility disorders such as achalasia. Endoscopic findings in eosinophilic esophagitis include edema, vertical furrows, white exudates, and concentric rings. However, endoscopy may be normal in some patients. For this reason, all children undergoing endoscopy for upper gastrointestinal symptoms should have biopsies taken. To confirm the diagnosis, the key histopathological finding is a count of 15 or more eosinophils per high power field. But other features such as basal zone hyperplasia and dilated intercellular spaces may also be observed. The first step is to discuss the available treatment options with patients and parents. We need to consider age, treatment burden, severity of symptoms, and availability of treatments. The first-line options include dietary and pharmacological treatment. Exclusive elemental diets have a high efficacy but low compliance rates and should be reserved only for those patients who are refractory to other treatments. There are different dietary regimens available based on restricting the foods with a higher allergenic capacity. A 6-food group elimination diet consists of eliminating the food groups most commonly associated with food allergy in the pediatric population, including cow's milk protein, wheat, egg, soy, tree nuts, and seafood. Other less restrictive empirical dietary elimination schemes, such as the 4-food group elimination diet, or a step-up strategy by starting with elimination of 1 or 2 food groups as milk and meat, and then stepping up to a 4-food group elimination diet, and eventually to a 6-food group elimination diet in non-responders. Pharmacologic treatment includes PPIs and swallow topical steroids, borrowed from asthma treatment. PPIs work independently of controlling acid reflux, having anti-inflammatory effects, and can also downregulate eotaxin 3, one of the main chemoattractants that bring eosinophils to the esophagus. The other option for pharmacological treatment is the use of swallow topical steroids, such as fluticasone and budesonide in different formulations. However, there are patients who do not respond to the therapeutic options we have available, and new treatments are currently being developed, such as biologics, that have shown promising results. An important step is monitoring clinical and histologic response to consider either maintaining the initial treatment, switching to another therapy, or even considering a combination of treatments. So different biologics have been studied with variable results. Early trial with these biologics, including mepolizumab, were less encouraging. However, there are current studies that are promising. Dupilumab has recently been approved by the FDA in the United States, and there are new drugs being developed, such as anticyclic 8 antibiotic, which has been studied in eosinophilic esophagitis. In my view, these new drugs may be considered as an option in cases that are refractory to other currently available treatments. Endoscopy and biopsy are the gold standard for disease activity monitoring. The pediatric EOE symptom score and the dysphagia symptom questionnaire may be used to assess symptoms of EOE. There are emerging tools and techniques that might be useful for monitoring patients, including some less invasive procedures, such as unsedated transnasal endoscopy, esophageal string test, and cytosponge. Other tools, such as FLIP or endoscopic ultrasound, may be useful in patients with persistent dysphagia. There are some different serum and urine biomarkers that have also been studied, but have not yet been shown to be useful in clinical practice. More recently, an index of severity for eosinophilic esophagitis was developed by a multidisciplinary team of experts. This scoring system uses a point scale of 1 to 6 for mild, 7 to 14 for moderate, and greater or equal to 15 for severe eosinophilic esophagitis, considering histology, endoscopy, and symptoms. This score will possibly allow clinicians to grade the severity of eosinophilic esophagitis that might be useful to guide choices of management and improve patient care. When we have the diagnosis confirmed, we repeat endoscopy in 8 weeks after 8 weeks of high-dose BPIs. After this, if there is improvement with high-dose BPI, we keep the patient on this treatment. If there is no clinical or endoscopic response, we switch treatments, either to dietary treatment or to swallow topical steroids according to the family preferences. If the patient does well clinically and endoscopically, we monitor patients every 6 months to observe improvement of symptoms and also growth. And periodically, we do endoscopy according to the clinical presentation.
Hello, my name is Arjan Bredenoord and I'm a consultant gastroenterologist at the Amsterdam University Medical Center and professor of neurogastroenterology and motility at the University of Amsterdam in Amsterdam, the Netherlands. Today I'm going to discuss the diagnosis, treatment and management of adult patients with eosinophilic esophagitis. We'll discuss a case today of a 29-year-old female. She has symptoms of epigastric discomfort, heartburn, and dysphagia over the last 5 years, which has led to some adaptation of eating habits. She's drinking after every bite of food now. Her personal medical history tells us that there's allergies to nuts, soy, and legumes, and she attempts to maintain a target elimination diet for her allergies, but she admits she is not consistently adherent. There's a negative family history. Endoscopy is performed, showing furrows, rings, and mucosal edema in the esophagus. A mucosal biopsy of the esophagus is performed, showing a maximum eosinophil count of 63 eosinophils per high power field. Further on, blood tests were normal, with a complete normal blood count and normal basic biochemical test, and no eosinophilia. The most important differential diagnosis in such a patient is gastroesophageal reflux disease, next to, of course, eosinophilic esophagitis. But there are some important differences between EOE and gastroesophageal reflux disease. Patients in EOE, the predominant symptom is dysphagia, while in GERD, it is more heartburn and regurgitation. Food impaction occurs in EOE, but is very uncommon in GERD. Further on, the majority of patients in EOE are males, while in GERD there's a more equal gender distribution. Endoscopic findings in EOE are often typical, with edema, rings, exudate, furrows, strictures, crepe paper esophagus, or narrow caliber esophagus. And only the minority of patients have absolutely no abnormalities at all. While in gastroesophageal reflux disease, the majority have a normal endoscopic appearance, and a minority may have erosions or ulcers, or even a Barrett's esophagus. In the histology, in EOE, there's many eosinophils. For the diagnosis, it's required to have more than 15 per high power field. Now, eosinophils are relatively rare in reflux disease. You may see a few, but more than 5 is really uncommon. The etiology of EOE is immune mediated or antigen mediated, while in GERD, it's obviously reflux disease. And patients with EOE often have other atopic conditions associated to the EOE, such as allergic asthma, atopic dermatitis, and allergic rhinitis. In ambulatory pH or pH impedance testing, searching for reflux, in EOE, the test is often negative, while in GERD, it may show pathological acid exposure and a positive relation between the GERD symptoms and reflux. So going back to our patient, she has both heartburn and dysphagia, but there is substantial atopic comorbidity. The endoscopy shows furrows, rings, and mucosal edema, which fit very well with EOE. And there's a very high eosinophilia in the esophagus. So it seems clear that this patient does not have gastroesophageal reflux disease, but instead suffers from EOE. So the current treatment options for adults with EOE are, for first-line options, PPIs, topical corticosteroids, and diets. And each of these treatments has its own advantages and disadvantages. PPI is a widely available medicine and has an efficacy of EOE for histological and clinical remission of about 50%. There's also relatively few side effects with PPI, so this could be a relatively good first-line treatment. An alternative is the topical corticosteroids. Often budesonide is performed. Now, in some countries there are on-label therapies, while in others there's only off-label use of steroids available. The topical steroids on-label often have a good efficacy. Over 90% of the patients gets into histological remission, and then around 70% gets into a clinical remission. So this is also a good first-line option. Finally, another first-line option could be an elimination diet. Now, the results are rather variable. Some studies report a good success rate of dietary treatment, while others describe that it's more challenging. A disadvantage of the elimination diet is that if patients respond clinically to elimination of certain food groups, it doesn't mean that they also have a histological response. So you still need endoscopy with biopsies to check for each elimination of each food group. Promising new treatments for EOE are the monoclonal antibody dupilumab, which targets the anti-IL-4, IL-13 pathway. And another treatment option would be mechanical dilation. This is performed endoscopically by introducing a balloon or a bougie in the esophagus. Now, the dilation has an effect on the stricture, but it has no effect on the underlying inflammation. So basically, it should always be combined with an anti-inflammatory treatment. So let's get back to the patient case now. In this 29-year-old female, there are very few fibrostenotic features here. And so I think she would be well suited for an anti-inflammatory treatment. I think all the options could be discussed with the patient, and then in a shared decision-making process, the best option for this patient is selected. There are several studies ongoing at the moment exploring new therapies for EOE. There's a study with the SP1 receptor antagonist. There are studies targeting the IL-5 pathway, cyclic 8, the IL-13 pathway. A study is just finished with an antibody against IL-4, IL-13 with the compound dupilumab. It showed that weekly dupilumab injections resulted in an almost 60% histologic remission and also a symptomatic benefit of those patients that were treated with dupilumab versus placebo. And this suggests that dupilumab could be a valuable addition to the therapeutic armamentarium of the gastroenterologist and allergist treating patients with EOE. So after anti-inflammatory treatment is initiated in this patient, she is seen back after 3 months. At the clinic visit, the clinical response is assessed and endoscopy with biopsies will be required to see if she is now in histological remission. If she is, the treatment will be continued because we know that stopping anti-inflammatory treatment in EOE will always lead to recurrence. There are several ways how we can monitor disease activity and treatment response in adults with EOE. The most obvious one is, of course, the assessment of symptoms. Now, in the clinic, this is often merely a question. How do you feel? Do you have ongoing dysphagia? Did you have any food infections? In clinical trials, we often use patient-reported outcomes, such as the dysphagia symptom questionnaire, the DSQ, or the EOE activity index. Now, it's very important to realize that symptoms do not correlate well to histological activity. So you will always need to do assessment of histology in order to know if a patient is also histological in remission. And this is important because you want your patient in histological remission to prevent that there will be progression to a fibrostenotic disease. Now, in current clinical practice, the only way to do this is with endoscopy and biopsies. In the biopsies, the pathologist will do an H&E staining and will count the eosinophils in dense eosinophils high power fields. The highest value is used here. Also, we score the endoscopic abnormalities using the ERAFS scale. This is a scale which describes the edema, the rings, the presence of exudates, furrows, and strictures. And this is a measure of the fibrotic and inflammatory activity of the disease. There are also quality of life instruments used in clinical trials, but again, these are not regularly used in clinical practice. There are a few techniques being developed to overcome the problem that for disease monitoring and measurement of response to treatment, an endoscopy with biopsy is always required. Some of these are very promising. There's the string test where patients swallow a string that's then attached to the cheek. And after a night, the string is removed again, and then it contains inflammatory proteins that reflect the inflammatory state of the esophagus. And another device is the cytosponge. This is a sponge in a capsule that is swallowed. A string is attached, and after the cytosponge is swallowed, the string is removed again, and then cells adhere to the sponge and can be analyzed, and eosinophils can be counted. There are other techniques that can measure the distensibility or fibrosis of the esophagus, such as the functional lumen imaging probe, FLIP, often used now in clinical trials, and serum and blood biomarkers for EOE are being explored as well. This far, these techniques are not ready for clinical practice yet. Recently, an index of severity for EOE has been introduced by an international consensus group. This EOE severity index consists of symptoms and complications inflammatory features on endoscopy and histology, and fibrostenotic features. The features and symptoms and complications get points, and then patients with higher scores are classified as being more severe than patients with lower scores. Perhaps in the future, this score can be used to further divide patients into certain treatment categories.